or should not, but we want to give that information to our audience. And with that, I know Dr. Lewis, you're one of those people on the front line as a surgeon, and you have taken the first round of vaccines. And just want to get your overview on that, how you feel about it, what you think about that.
Well, I would kind of echo what Dr. Rayford has already said. We know that the things that we've already been doing, the social distancing, the masking, washing hands, have been helpful. But we need all of our tools in action. And the vaccine, I feel, is one of those things. Also, want to clear up at the beginning of this, neither Dr. Rayford or I are experts in virology, but we have basic medical background, and our hope today was to talk in just kind of plain terms about how we feel about the virus as well as the vaccine. For me, looking at how this vaccine was developed, understanding that it is a new vaccine, but not a new technology. They've been working with these particular mRNA vaccines for 30 years. I felt comfortable doing it. I do not see any reason to be concerned about side effects other than what we've already seen with the initial reactions. So I felt comfortable that this would allow me to do everything that I can do as an individual to do my part to try to stop the pandemic. So I felt very comfortable.
On that subject, and I know both being African and African-American males, there's a lot of questions, a lot of concerns out there about that the vaccine was developed within a year. How do you feel personally about that?
I don't, you have to kind of understand in the end what things were done to shorten the amount of time that's required to develop this vaccine. I think, and again, you correct me if I'm wrong, but one of the things is how the type of vaccine it is. Because this is a messenger RNA, we're not dependent upon melding DNA or developing it in a chicken and going on. So that cuts down some of the time period that's required to just generate enough vaccine. And then the other thing is how they went about the testing of the different phases. Rather than doing them sequentially, they ran several at the same time. And that allowed the time period to go from initial development to having a vaccine that they thought was safe to be cut. You still had the same number of people being tested and evaluated at the same amount of time. They were just done concurrently rather than sequentially. And that's where the shortness of time. There were no true shortcuts in the amount of safety that was required. They just did them in a slightly different way. So again, I think all of the boxes were checked to make sure that this was a safe vaccine.
Thank you for that, and I certainly want to come back there. And this is a question that has been thrown at me, everything from religion to all the myths, from experimenting on the African-American male, and all of these things. As an African-American male and internal medical specialist, what do you think about that? I know we've seen certain videos with saying that, the virus was made out of this, out of that, they're giving you the virus. Is that true? Are they actually giving us the virus in the vaccine?
No. So the two vaccines, Moderna and Pfizer vaccines, they're actually not giving any virus-derived products. The messenger RNA is the closest thing I can think of as a recipe. And so we're introducing the recipe to make the protein that the immune system is going to recognize. And that's what goes into the cell. The recipe is then used in the cell to create those proteins. The proteins are recognized by the immune system so that it can be on alert for that next exposure to coronavirus and decrease symptomatic coronavirus and decrease severe coronavirus. We're still learning. So we're giving the vaccine to different groups, but we're still studying the vaccines. And so we're still learning things that aren't fully determined because we're also learning in real time. So how long you're protected, as well as whether or effectiveness or 94.5% effective. What we're seeing is the way the studies were designed, that was looking at symptomatic coronavirus infections. And we know that people who are symptomatic can spread it, as well as people who don't have symptoms. On an individual level, the symptomatic people can potentially spread it more individual. Collectively, asymptomatic spread is a significant issue for the communities. And so we have yet to learn how significant the reduction in asymptomatic coronavirus spread is. And if we learn that, and we learn that these vaccines are, that's even more evidence that these are really, really, really good tools that we have to add to what we're currently doing. And, you know, go back to maybe starting it out the way, we're not going to get out of this unless there's enough immunity to coronavirus in the community. And immunity occurs essentially in two ways. You get the virus and you take your chances at having severe coronavirus and death, or you use strategies like immunization. And a combination will get enough immunity in the community so that coronavirus levels can go back to some of the other lower levels that, you know, we don't call pandemic anymore. It goes to kind of a low level still in the community. I don't believe coronavirus is ever going to go away, but it's not the same risk if a significant portion of the population. So you've heard terms like herd immunity, and that's just simply saying enough immune systems are primed to recognize coronavirus and fight it off. We're going to get that through infections, but there's a lot of risk. And we're going to get that through vaccinations. Vaccinations represent a much, much safer option to get us to that point. The other thing to know is, at this point with vaccines, it's more about individual protection. So I took the vaccine as well, and at this point, it's about individual protection. If you get enough individuals to take the vaccine, then it becomes collective protection. And so, you know, what my task is, and so in our clinic, my task is to help present the information so that people can make the best decisions for themselves. Hopefully, it's based on the science and they're weighing the risk of natural coronavirus infection versus vaccination, but making a decision to protect themselves individually first and then collectively through vaccination.
I want to reiterate one of the things that we talked about before we went live on our Facebook. You counted off 6 to 8 steps. So we're not masked, but we are, the CDC guidelines, distant on both ends. And that's why we're seeing kind of awkward here. I want to come back to that. One of the things about after we take the vaccine, are there any side effects? And Dr. Lewis, you've taken your first round. Have you had any side effects or any awkwardness or anything since you've taken it? I don't know the time period that you've taken it.
For me personally, the only thing I felt was some soreness at the injection site, and that was gone by the next day. Other than that, I haven't had any side effects or symptoms related to the vaccine.
And I know that we're not here tonight to tell anybody, hey, you need to take it. We're just here for information purposes. But as a physician, and I know you're a surgeon, you talked about your background in different fields, are you afraid of Rayford, getting back to the vaccine and what this thing is, we've got 2 vaccines that's been approved at this point. What is the difference between the Pfizer and Moderna? Because some say you gotta, the Pfizer is a number one, but it's gotta be a certain temperature. And then you've got the second one that come along. It doesn't have to. Some questions might be if they do the same thing, why they got to have different. That's my question.
So, why there's 2, and in fact, Pfizer and Moderna vaccines are 2 that have been authorized here. The United Kingdom actually authorized another vaccine, the AstraZeneca vaccine. So going back to the process, the existing messenger RNA technology has been around for decades. Also, our ability to sequence viruses and to get the genetic makeup of the viruses is actually a lot quicker than it's ever been. So in January, the genetic structure of the virus was known. In March, vaccine candidates were being tested out. And so studies of coronavirus vaccines were started in March, actually. And so that wouldn't have been possible without technology being at the level. And what you had was many, over 100 vaccine candidates that were that started to be studied. Those that have kind of gotten to the authorized phase have been, the 2, the Moderna and the Pfizer, both use messenger RNA technology. The difference is Pfizer's vaccine requires a colder temperature for stability than the Moderna vaccine. There's differences logistically in terms of how the vaccines are batched. What I've seen is larger health systems are better prepared with cold chains and refrigeration and staff to handle Pfizer. Maybe smaller clinics are better able to handle Moderna because you can use more of a standard freezer. And so the vaccines, like Dr. Lewis was saying, that a lot of steps in the process were done at the same time. Another big thing to happen to where we had the vaccine authorized on December 11th, but we were shipping out vaccines 2 days later. The step that usually takes a lot of time, that the companies, while they were studying the vaccines, were actually making hundreds of millions of doses, so that if they got approval, they would be able to ship those vaccines really soon after the authorization. And that's what you saw with Pfizer and Moderna, that they were ready to ship, really soon. And even companies today that are not going to be successful, they probably made hundreds of millions of doses. And that's a chance that they took. They were, that risk was shared by the governments of many different countries, including the United States, giving the manufacturers billions of dollars to start manufacturing those vaccines, and on the chance that they get approved, to start releasing those doses really, really soon. Companies previously wouldn't make hundreds of millions of doses unless they, the old process, because it's such a time and financial commitment. And so that's something that also happened while the studies were going on, that they were taking risks. They were using their existing workforce and their existing infrastructure to make hundreds of millions of doses while they're still figuring out whether it's going to be helpful. And so that's why we have, we've had the ability to vaccinate over 2.5 million people in the United States, 2.5 million vaccinated so far, with more vaccines on the way. And so that's one of the things that was able to help us get there really quick. Other simple differences, Pfizer vaccine, you can be as young as 16 and get it. Moderna, just 18. Both are 2-shot series, so you have to get a first and a second shot. Pfizer, it needs to be 3 weeks between the shots, and Moderna needs to be 4 weeks between the shots. We think that you get the best protection about a week after the second shot. There may be some protection that happens after the first shot, but at least how they were studied, the best protection seems to happen a week after the second shot.
Thank you. That's a lot of good information. Please go ahead.
One thing I just wanted to add to that is that, and you were asking about the differences in why one has to be refrigerated refrigerated, one
Yes.
doesn't. And a lot of that has to do with the way the mRNA is encapsulated. They use a different kind of fatty globule around the mRNA. And the one that Pfizer uses, that particular fatty globule requires that refrigeration, whereas the one that Moderna uses does not. And that's why you have the difference in the refrigeration temperatures.
That's a very good question, and thank you for that. And I also want to say this right here. I'm trying to keep it plain, we're trying to put the information out there, but this question has come up. There's a dose for the essential workers, and there's a different vaccine for the normal African American community. I've never understood that, but that question has been out there, and I don't know which one we want to take that to, I guess, to kind of put that myth to rest.
Yeah, so that there's no different dose for different groups. It's a standard dose for everyone, with Pfizer, standard dose for Moderna. There's some things we're going to learn over time, but at this point, there's a standard dose, you need 2 doses of both. Other difference is how what the Pfizer dose is measured in, what Moderna dose is measured in. Those are informed based on how they were studied. A question people ask, well, why 2 shots instead of 1? That's how it was studied. There are some more vaccines in the pipeline that are looking at 1 dose. We may, as time goes by, we may learn that the effectiveness of 1 dose is good enough that, if we add 100 million doses, if we can get it to 100 million people instead of 50 million people, that may be beneficial, something that we may learn as we are trying to kind of claw our way out of the tough part of this crisis.
Thank you. And again, those, go ahead.
To add to that, it's important to understand that African Americans were included in the initial studies for the safety of these vaccines. So, and they were not given a different dose. It was the same dose for everybody. And they found that it was just effective. There was no difference in the effectiveness of the vaccine based upon the color of skin. So,
thank you, because that's a myth that's out there. One of the other things, I don't want to put either one of you guys on the spot with this question, but I think they were saying that there would be 20 million doses actually given by the end of December or January.
I think that's a campaign.
Is that a campaign?
I think so.
Okay.
I think it was a campaign
Okay.
promise. As you can see with the different vaccine logistics, that's getting, I've heard someone say getting that final mile, and that's from, the refrigerator to the arm. Logistically, you really have to be prepared, and I think, not to make this veer, I think, unfortunately, we didn't have a single logistical way to do it. We had 50 plus ways each state has kind of handled logistically. Each state was given an allotment, and each state was distributing their allotment through different kind of systems and things like that, and sometimes the system itself had to develop its own logistics, where we're going to do it. It was an opportunity for leadership. I think when we look back and kind of, do the kind of the grand accounting, there's a need for a single unified voice. There's a need for leadership at the, there's a need to have, we needed one way to treat, handle the coronavirus crisis. 50 different ways and even more isn't enough. I think, logistically speaking, my hope is to get, that we'll have an approach that will, come up maybe a more unified approach to get the vaccines across that last hurdle, that it doesn't stir, the vaccine itself isn't what saved lives, it's the vaccinations. And so if we can really get the vaccination part, the logistics of vaccination, then I think it'll get us a lot closer to that point where we can say, hey, we've dealt with coronavirus and we're reestablishing what normal is.
Okay. So what I'm hearing is you guys feel pretty comfortable probably with the time frame that the vaccine, I know there's essential workers out there. You guys are certainly essential workers. You guys feel kind of comfortable with the way that it's being disseminated at this point?
Well, certainly it has to be a process. And I think, particularly in our community, it was initially given to those that were in direct contact with patients with positive coronavirus testing. So you want to be able to protect your health workers first, because if they go down, now you have no stopgap. There's no dam to stop the flow of the coronavirus. So I think having those healthcare workers be the first ones to receive it was the right way to go. And then to move from that sphere of definite contact with the infection out from that, I think is a good process to go about how to disseminate that vaccine.
Okay. Well, we're certainly trying to put this information out from Project Elect. We're getting kind of close to the end. What I do want to say is that we're here with Dr. Vernon Rayford, IMA, internal medicine. We're also here with Dr. Eric Lewis, and we're getting ready to cut this off. I don't know if we have any questions or anything out there. We have one question from the audience.
We do have a question,
Okay.
and that question is from Mr. Taki, and it says, I had COVID 3 months ago, completely messed up my smell. Everything smells like burnt toast to me. Why? And he also wants to know, what can he do?
And I think I know Mr. Taki. He's 28 years old. If that's a question, I think I do know him, yes.
Yeah, so definitely the coronavirus can affect taste and smell. We're still learning about all the effects of coronavirus. I go back to we're learning in real time. There's not a lot of guidance on what will bring back the taste smell alterations from coronavirus other than time. There's some other scenarios, and I've had patients who've had issues with taste and smell. There's supplementations and things, and I would encourage him to seek out a medical provider to kind of talk about what other things that have been done for other conditions that affect the taste and the smell. But it's worth knowing. I guess that question kind of makes me think about really letting if I ever have the microphone, letting people know that at this point, anything can be coronavirus. So in terms of symptoms, I think it's really, really important in terms of just, really assessing coronavirus. Anything, a sneeze, a cough, you lose your taste, you lose your smell, having GI issues, diarrhea, belly pain, headache, muscle aches, fatigue, any of that can be coronavirus. So if you have any symptom that you didn't have the day before, just get it checked out. And the value of getting it checked out, if you have coronavirus, everybody around you has a risk of coronavirus, and they need to know to be tested. You need to know that you need to quarantine, isolate for a period of time so to prevent spread. So if you are feeling different today than you were yesterday, it could be coronavirus. It's the most common thing. It may not be allergies. I haven't seen a winter cold. It's been coronavirus. And so just thinking about the symptoms of coronavirus, shortness of breath, chest pain, cough, those things go along with everything else. And then, with coronavirus, some people have it and just don't have any symptoms. And so we really have to get better about recognizing coronavirus. So preventing coronavirus, recognizing coronavirus, and vaccinating for coronavirus are three of the things that's going to really help us get back to that point where, we're reestablishing normal.
Good information. Thank you for that. So, Dr. Lewis, I have noticed, though, is you guys both have had the first round, but you still have your mask, and we're practicing the social distancing and all of that. Just because you've taken the shot the first round or the second round, should we stop practicing that?
Absolutely not. First of all, the vaccines are not 100% effective. Secondly, we are still learning how long you actually have immunity once you achieve it. So all of the things that you were doing before still need to be done. We're just going to be adding in now the effectiveness of the vaccine.
So, you got one more question?
We want to let our audience know that the sound quality has gone up a lot better, and that
Okay.
please send in your questions as soon as possible. We have a few minutes left.
Okay, and again, this is Project Elect Facebook Live with Dr. Vernon Rayford and then Dr. Eric Lewis. We're just discussing the coronavirus and the vaccine. For any questions that may be out there, we'll be live for a few more minutes. One of the things that I wanted to bring up, since we are kind of going back and forth to the vaccine and back to the basics of what started coronavirus, one thing that I've always learned is I think there was a bomb technician. He was running and he had on back of his shirt, "If you see me running, you might ought to run." With me, if I see these medical professionals, they're concerned about this. I should be concerned as well. I'm probably going to be influenced a little bit. So one last question I have, and then we can go back to the audience. Vulnerability. The people that are most vulnerable to getting this virus. And I know we all have parents, or some may be going on, but grandparents, loved ones, and so on. But I've noticed a lot of the younger generation, they're not paying attention to the CDC guidelines. Any comment on that from either one of you?
Yeah, so I think in terms of vulnerability to infection, everybody who hasn't had coronavirus is vulnerable to coronavirus infection. And even some people who've had coronavirus before, we're seeing situations where people are getting reinfected. So it's probably not as common, but anyone who's not been infected with coronavirus is vulnerable to the virus. The tragedy is not that, you know, the virus can spread to young people and they not have any issues. The tragedy is that young person spreads the virus to. So there's a lot of families who are burying mothers and fathers and grandparents because coronavirus was brought into the household by the younger family members who were unfazed in terms of the virus impact on their self, but will psychologically not be the same because they've buried their matriarch or the patriarch of the family. And so there is a vulnerability to being infected, and coronavirus has proven that if you give it an opportunity, you know, if you're having a meal around your family and you're eating without a mask, that's enough, you know, and so it's proven that it will infect you if you give it an opportunity. The other vulnerability is the vulnerability for bad outcomes and death. We know that age is a risk factor for severe coronavirus and death, that, you know, as you get older, as you count by tens from 60, the rate of death goes anywhere from, you know, 2% for everybody to 8% up to over 25% for the older patients. Those who have chronic medical conditions that are common around here, high blood pressure, heart disease, diabetes, obesity, those are risk factors or vulnerabilities for severe coronavirus. And those are also vulnerabilities for death from coronavirus. So there's the risk of getting infected. And yes, younger people are less likely to be symptomatic. Younger people are less likely to have severe coronavirus. They're not shielded from that. Unfortunately, there's been children less than 4 years old dying from coronavirus. There's been children dying from coronavirus, young adults dying from coronavirus. So age doesn't shield you from all the bad effects. So it's really important for young people to know that the reason they're being safe is it should be that they're trying to keep the people they love and value the most safe. That, you know, you have older adults and people who have risk factors that have done everything right. They've kept the crowd small. But the one thing that they did, and it doesn't feel like they did it wrong, was that they let their guard down around their family members. And that's all it takes for coronavirus. So there are family members who gathered for Thanksgiving, family members who gathered for Christmas, and the next time they're going to see each other in a couple of weeks is going to be the funeral for the family member who caught coronavirus and unfortunately has died. I want to be positive and just take the day as it comes. But again, the pattern for coronavirus is spike in cases, followed a couple of weeks later by a spike in hospitalizations and spike in deaths. And, you know, you may not be hearing, you know, hospitals screaming in the newspapers and on social media, but the hospitals are really close to their limits. They're real close to their limits. And so the care, there's a risk that the care that people get is going to be different because the hospitals are so overextended.
Wow, thank you. That's awesome information. I have one more question myself. You have one?
I have one question.
Okay.
Again, this came from Mr. Taki, and it says, is it okay to get the COVID shot and the flu shot in the same day?
Dr. Lewis, Dr. Rayford.
That's actually a good question. I don't know that they've even looked at answering that question in terms of co-administration. I know that wasn't done in the studies. So we'd have to get back with you on that. I'd have to look at some resources, ask people who are much smarter than me, whether or not, in general, vaccinations, many of them are fine to be given together. I know that it hadn't been looked at in a large enough number of people as far as kind of getting both the coronavirus vaccine and the flu vaccine at the same time.
That's a good question. And so we will be leaving this on Facebook. And so if there's questions to be asked later, you guys will go in there and answer those questions. I have one more, and I don't know who to ask this, but I'm going to ask Dr. Lewis. The new strand, and I'm always watching CNN, and I learn a lot, and then again, I get off track. They're saying it's more contagious, but the vaccine may be as effective. Is that, and I'm asking because I have no idea what the new strand is, only they're saying new strand.
Yeah, so what they've seen, this new strain of virus is much more contagious, meaning it's much more easy to catch it. That doesn't mean that it's more deadly. You don't have an increased risk of death as a result of it, but it's easier to catch. So far, from what I've heard, the vaccine should still be effective against the new strain. Of course, we haven't had a great deal of study on that, so that still needs to be proven. But nothing so far has indicated that the vaccine will not be effective even against the new strain.
Gotcha. Thank you. That is all of my questions at this time. We're getting ready to wrap up. But I will want to know, we will be back. We'll be coming back on this. I don't know if it's next week or the week after that, but we will be coming back. Any closing remarks from either of you guys? We're getting ready to close out.
Yeah, so coronavirus is serious. Coronavirus is deadly. We can do our part to keep as many people who are close to us and who are not, keep them safe. The vaccines are not a replacement for the other mitigation strategies. It's an addition to our toolbox. I believe that, you know, the people that we're vaccinating now is going to go a long way to helping us manage coronavirus in the spring. We're more likely to have close to normal spring, summer, falls if we can get high levels of vaccinations. I would encourage people to try hard to hold out, to try to make sure that they're doing everything they can to be safe, to reevaluate stuff that may not be a priority. In terms of, you know, what's number one. Number one is so important, is more important than number two. Everything can't be number one. So there's some priorities that it's really important to keep people safe. And that means birthday parties being different, funerals being different, sporting events being different, because if we can just do those things and kind of hold out, we can get to that point where these vaccines are really, really making the difference. Right now, the vaccine is not going to change 3,000 cases today. It's not going to change whatever number we'll see tomorrow. We're going to need to do those things that we did in the summer so we can get out, we can keep some healthcare resources, we can keep the system from being strained and breaking. We can keep a lot more people. And I also want to just know that, you know, coronavirus is harming a lot of people, but there's a lot of other harm that's happening from other things that can't
get taken care of in the right way due to coronavirus stretching our resources. So no, coronavirus isn't the only thing that's taking family members out. It's just coronavirus has so strained our resources that we can't do the things that we used to could do. So take it seriously. Let's do those mitigation strategies. Use science and information. If you have questions and concerns, go to someone who has that background to kind of help answer those questions. Dr. Lewis and I can, really say, hey, this is what decision we've come to by looking at the data. Ask those questions. Now is the time to ask those questions and rely on science. And as much as you can, rely on science and not necessarily, hearsay and things like that.
Thank you for that. Dr. Lewis, any closing?
Yeah, I think a couple of points. One, going back to the vaccine. The vaccine is not the virus. It is a message to the body to help it identify when the virus is present. It is, I guess if you will look at how you identify an automobile, if you were to look at a Mercedes-Benz, you would recognize it by the emblem. But having the emblem is not the same thing as having the whole car. So what the body is doing is just giving, what the vaccine is doing is giving the body the emblem. And with that emblem, the body can now identify when the whole car is there. But they are not the same. The second thing is that you, at this point, have the ability to make a choice. You can choose to wear a mask. You can choose to socially distance. You can choose to get the vaccine when it's available to you. If you don't do these things, and our healthcare system is overwhelmed, the decision of what happens to you is going to be made by somebody else. And it may not always be what you would feel is the right thing for you. But we always have to take the overall system into account. So take advantage of the fact that there are things that you can do today to make this a better situation. Because if we don't, somebody else is going to be making decisions for you.
Thank you for that, and I am so delighted, and I wanted to thank again Dr. Rayford and Dr. Lewis for coming tonight and actually being real. Again, we're talking live from Project Elect, enthusiastic leaders engaging changing times. We're under the leadership of Pastor and our chairman, Jeffrey Daniel. We appreciate him renting out his facilities tonight. We thank our camera people, Fred Cook, Maurice Shelford, our question and answer there, Kenneth Wheeler. So again, we will be back at some point in time. Please upload your questions. These gentlemen will get back with you, and we'll be letting you know the next time we go Facebook Live. Again, I'm Robert Hall, co-chairman, Project Elect. Thank you and good night.